Good afternoon, everyone. Thank you for joining us at the California Dialogue on Cancer, CDOC's Cancer Surveillance Data webinar series. My name is Sheila Senyo, her Strategic Alignment Specialist for the Comp Cancer Program and the California Cancer Registry. Please feel free to introduce yourselves in the chat with your name, pronouns, and organization, and where you are joining from. So I'll go over some housekeeping while everyone is typing in your intros. All participants have been muted, but we'll leave the chat open for questions. We'll also have an allotted Q&A after speaker's presentation, and please stay until the end of the webinar to participate in a short evaluation. Again, for those who are just joining us, please type in the chat your name, pronouns, or organization, and where you're joining from. The California Comprehensive Cancer Control Program is a CDC-funded program that provides leadership and coordination of statewide comprehensive cancer control efforts. The Comp Cancer Program leads the Cancer Control Coalition, which is CDOC, and is also required to develop and implement a state cancer plan. Currently, we're still implementing strategies from our current 2021-2025 state plan, but we are in the process of revising the next iteration of a 10-year state plan. Next slide. As a background information, these are just the current cancer plan topic areas. CDOC works closely with the Cancer Registry and other partners to help implement strategies from the surveillance topic areas. The Comp Cancer Control Program works closely with the California Behavioral Risk Factor Surveillance System, or BRFSS. The California BRFSS conducts a yearly assessment of a variety of public health topics, including demographic information, cancer prevalence and screening, tobacco use and control, gender-specific health screening such as the breast and prostate cancer, asthma diagnosis, alcohol consumption, and other health concerns. Today's session will explore how BRFSS data can inform cancer plan measures we're working on, or just simply provide a deeper understanding of its relationship to cancer data. Today's presenter is Nick Cuvelier, a research scientist too for the California Cancer Registry. His time is currently dedicated to the behavioral risk factor surveillance system activities, such as developing fact sheets and reports, evaluation, and cancer development and analysis of the BRFSS, as well as dissemination of the data sets. Prior to joining CDPH, Nick worked at UC Irvine as an assistant specialist focusing on both the CDC PFAS health study, as well as developing statistical models to estimate exposure to pesticides. Nick graduated from University of California, Irvine with his MPH with a focus on epidemiology. And he also has an MS from the University of California, Riverside in neuroscience. Please welcome Nick Cuvelier.
Hi, everyone. Thank you so much. And I'll try to pull up my slides. So I should go ahead and share my screen. All right.
We can see it.
Okay, perfect. So thank you so much for having me. So basically, as she mentioned, I'm here today basically to talk to you a little bit more about BRFSS and how I think it's related to cancer research in general and how I think it can benefit cancer surveillance. And I want to start by saying thank you, first of all, to Amy Wynn, who is an intern here specifically because I'm using some of her slides she developed as an intern here to give us a little bit of background about BRFSS. I know I have talked at a previous CDOC meeting a little bit about BRFSS data. Some of you might be very familiar with it. Some of you may not be. But I do want to spend a little time today going into a little bit more detailed background about the history of BRFSS, a little bit about its structure and exactly what it is, and also Sandy and Katrina, who obviously support everything we do with BRFSS here. Get this to move forward. Okay. So first, just a little bit of background starting off with what is BRFSS in general. So BRFSS stands for Behavioral Risk Factor Surveillance System. So this is just a state-based cross-sectional telephone survey. This is conducted every single year. It's conducted via random digit dialing, and they conduct it by calling both landlines and cell phones. There's a hope in the future someday we can extend this to also looking into doing web surveys. But currently it's just landline and cell phones. And it collects data from non-institutionalized adults who are at least 18 years of age. And really the bulk, as the name suggests, the bulk of the data is looking at personal health behaviors that put health at risk, or on the opposite side, that prevent serious health conditions from occurring. So we're really looking at personal health behaviors that, especially when we look in terms of chronic diseases, we're trying to get a picture of what behaviors both are putting the population at more risk for developing these conditions, or what are we doing a good job at that are going to help us prevent those conditions from occurring, and what are we not doing such a good job at, and what conditions can we expect to occur as a result. So it just gives us a better overall idea of kind of the health risks that are going on in the population. And this survey is a collaboration between the CDC and all 50 US states and territories. All right. And I also wanted to go a little bit through the survey content here, because there's three main portions of the survey. We have what are known as the core questions. So these questions are asked by all states and territories. And within the core, we have what are known as the fixed, rotating, and emerging questions. But your core questions are going to remain constant, again, down to the exact wording. So across every state and territory, all the questions in a given survey year are going to be exactly the same. So if you go to the national data set, every single state and territory has the exact same list of questions within the core. Then we have what are known as the optional modules. So these modules are more specialized topic questions. These are supported by the CDC, but states can basically opt into whether or not they choose to include them on any given survey year. You can also choose to include them on one year, skip them for a few years, include them on another year, but they're always available, supported by the CDC. And then you can also go to, basically, if you go to the CDC BRFSS website, you can actually look up by optional module of interest, and for any given survey year, see which state included that specific module. And finally, we have what are known as the state added questions. So these are not specifically supported by the CDC. These are developed through the states themselves. And these questions are meant to basically address any state, local, and program specific needs. So basically, these are not given back. They're not part of the national data set, so they're not sent back to the CDC. So these are very specific just to the state data set that develops these questions. So for the fixed and rotating core questions, as you can imagine, the fixed questions, the ones that remain constant from year to year, they're pretty standard. A lot of them just focus on our demographic characteristics, or some basic queries on health behaviors, tobacco use being one of them. Your rotating questions are questions that are going to be, they can be asked on a rotating schedule. So they can be asked on odd years, even years, every 3 years, or every 4 years. And they can address all sorts of different health topics. On the years that the rotating core topic is not scheduled to be asked, it is supported as an optional module. So this always gives the state or territory the option to maintain this rotating core question on the survey, even on the years they're not scheduled to be part of the core. So this gives you the option to not have those gaps in years for modules that may be specifically important to a certain state or territory to address certain questions. And down here, we just have some of the general categories that the core consists of. And for those rotating core questions, on the odd years, in general, we have this hypertension awareness and cholesterol awareness. For even years, we have the HIV and AIDS questions, oral health, and our cancer screening questions, which include breast and cervical cancer, prostate cancer, and colorectal cancer. The 3-year core questions include seatbelt use, drinking and driving, immunization, sleep, and falls. And our 4-year core questions include fruit and vegetables and physical activity. All right. And we also have what are known as the emerging core questions. So these are questions that are meant to address anything going on in the field of public health that's considered urgent or high priority topics. So these are added on to the fixed and rotating core, and essentially they're added on and for 1 year and evaluated to see basically their potential value for future surveys. So this allows us to, for anything that pops up that's of importance, allows us to get a brief picture. So from the California perspective, kind of a brief picture of what's happening in the California population as important issues present themselves, and then determine whether or not this is something we need to keep an eye on, whether it should remain part of the core for the foreseeable future, whether it should be moved to an optional module potentially, or whether it's something that maybe no longer needs to be a part of the survey. So one example would be questions regarding COVID. And we also have some other examples here regarding the influenza vaccine shortage, the H1N1 flu vaccinations, healthcare access, and e-cigarette use. Okay. And for optional modules, I just have a list here of some of the optional modules that are available to us. Again, these are all modules that are supported by the CDC that we can choose to include on any given year. So we have modules like the pre-diabetes and diabetes module, the social determinants and health equity module, which is one I've talked about previously, the SOGI module, and the lung cancer screening, and also this cancer survivorship module, which is one I'll go into a little bit more detail about later. Okay, and finally, I mentioned this too, but again, we always have these state-added questions, which are developed by the states at their own expense. And because these are not funded by the CDC, they're not a part of the official BRFSS questionnaire, so they're not going to be listed on the BRFSS website. So these questions, if you wanted access to them, would be requested directly through the state BRFSS team. All right. And just to give a general timeline, again, there is some flexibility here. There's always challenges that come up, but we like to have a general idea of what we like to do for BRFSS. And by July, we like to at least start planning the survey for the following year. And that includes getting the cost per question in mind. By September, we want to start getting the state added question proposals down. October is when we want to start having the draft of the survey for the following year. We do have a data users meeting, and that's where we meet with a bunch of the data users, and in October is where we basically want to go over the draft of the survey for the following year, review it for any issues or any changes that may need to be made. October through December is the time where we're going to actually look at the state added questions and have our data collectors actually go through the pre-testing and programming period. And we hope to have this survey instrument actually finalized by December. And that way data collection can usually begin in January. And that way we can collect throughout the entire year, covering every month. And again, I'll mention this again later, but one of the great things about BRFSS is it's a free data resource. So in order to request BRFSS data, you can just follow these steps. You can always fill out a data use agreement by going through the CDPH website. I also do have the link here. Once you fill out the data use agreement, you just return it to this email. I would then forward you an SFTP form, which basically that's to allow you to get set up with a secure file transfer folder on our site. Once that's done, which our IT team would guide you through getting a folder, I basically, you'll notice if you were to fill out one of these forms, you specify which years of data you're interested in obtaining. I would upload those years of data to that folder on the secure file transfer site, and that would be it. You'd be able to access the data. One note here, we do have one policy where those who choose to purchase questions for the survey for 1 year following the data release. So for example, for 2023 is the most recent year of data that's been released. Once that data is released, there's a 1 year period where when data is requested, only those who purchased questions will receive the state added questions as part of the data set they receive. Those who did not purchase questions would only receive the core and optional modules. Following that 1 year period, so usually that's about the time we would release the 2024 data, anyone who requests the 2023 data at that point would also be able to receive the state added questions, whether or not they purchase questions for that year. Okay. And this is just giving you an idea of what modules are going to be coming up for, again, we have that rotating core schedule. So these are some of the modules that you can expect for the 2025 survey. So our hypertension and cholesterol awareness modules will be available, as well as the fruits and veggies modules. And for the optional modules, we do have a family planning module this year, as well as a caregiving module, prediabetes and diabetes, cognitive decline, as well as an industry and occupation module. Okay. And now, obviously for this meeting, I really wanted to go over both the cancer-related modules that are on BRFSS and some other modules I think that can help supplement cancer-related data. But specifically, we have a few different modules that are related to cancer data. One, we have our rotating core modules. So we do have a lung cancer screening module, a breast cancer screening module, cervical, prostate, and colorectal cancer screening. So these are on our rotating core modules. And we do have another optional module, which is our cancer survivorship module. So this has been funded in the past, not every year. So I'll go into more detail about this later. It's made up of 3 different parts: type of cancer, course of treatment, and pain management. I do think this is a really interesting module that contains a lot of great information. So I do want to spend a little more time talking about it later and kind of the questions that are within each of these subparts here. But so these are all portions of the BRFSS survey that relate to cancer. And I'm just going to jump right into some of the data that we have. Based on that rotating core schedule, the last screening data for cancer we have was 2022. So this is relating to breast cancer data. Or breast cancer screening data. We do have some calculated variables I want to have a chance to analyze as well, but this variable here is basically looking at women who reported having a previous mammogram, so screening for breast cancer. And this question is asking, for those of you who reported having a previous mammogram, when was your most recent mammogram? And basically here we have the percent of respondents, and we can see of women who reported having a previous mammogram, over 50% of them report having their most recent mammogram within the past year. If we look within the past 2 years, basically combining these 2 bars, over 70% of women report their most recent mammogram within the past 2 years. But about 10% of women report their most recent mammogram being 5 or more years ago. Okay. For our colorectal cancer screening module, so this question screened patients or participants who were age 45 and older. And the language for this question basically started by explaining exactly what a colonoscopy or sigmoidoscopy was, explaining that there are techniques to look and screen for colorectal cancer, and then followed by asking the participant, have you ever had either of these procedures done? So what we can see here, again, we have the percentage of respondents. So of all the participants on the 2022 survey who met this criteria, right about 60% of them said they had a colonoscopy or sigmoidoscopy performed before, and just under 40% said they had not had this performed before. And we also had the lung cancer screening module. So this was a calculated variable on the 2022 survey. So this had to do with the USPSTF recommendation. So this is for anyone who is a current or former smoker between the ages of 50 and 80. And basically the recommendation was having a CAT or CT chest scan within the last year to look for lung cancer. And you can see almost 95% of participants who met this criteria did not meet the USPSTF standards or the USPSTF recommendation for lung cancer screening. Okay. So those are like the direct measures for cancer screening or cancer screening modules we have on BRFSS. But one thing I really want to highlight is that I think there are other modules on BRFSS that make it a useful resource, whether you're looking at cancer screening or other modalities for cancer data. There's a lot more I want to do looking into these modules. So I want to preface this by saying this is just a very preliminary look just to get an idea of how useful these modules can be. So, well, I haven't had the time to run a lot of models or run the statistics yet, which is the plan moving forward. Right now, what I wanted to do was look at some of these modules and just group them with some of these cancer screening variables and just see if there's anything that might be interesting or worth investigating further. So that's all I've had time to do so far. So please take it with a grain of salt and just know this is kind of something. What I'm trying to do is just show that there may be things of interest, other variables of interest in the survey that are worth investigating alongside cancer screening data. So one of the ones I investigate, I talked about this module last time I spoke at CDOC, the CDOC meeting, are the social determinants of health. One of the reasons I think these are really interesting, there has been a lot of research done on how social determinants of health affect preventative health behaviors. I just wanted to list a couple of research studies I found recently that talk about this. So this first paper here looked at how social determinants of health are related to vaccination status in older adults. So this found that social determinants of health affect influenza vaccination status. So that they're directly related to whether or not older adults get the influenza vaccine. And also down here, we have two more recent papers that these were meta-analyses looking at studies that found that different types of social determinants of health measures, that when there were interventions that aimed to improve them, they were actually able to improve cancer screening rates. So this is one of the reasons I wanted to look at this within BRFSS. And I will preface this by saying, you know, when you talk about social determinants of health, this is a very broad term. If you look at the CDC definition, I mean, social determinants of health encompasses so much. It's everything that can affect our health, right? It can be economic policies, it can be housing, employment, pretty much anything. So you have to be careful. And when you just mentioned social determinants of health is a broad term, but I do think there's a lot if you dig into it and get a little bit more specific about which modalities of social determinants of health you're measuring. So these studies looked more specifically at, I think it was social economic status, they looked at employment, they looked at rurality, and a few other measures that they found to be specifically related to improving cancer screening rates. So within the BRFSS survey, there were two different modules I was interested in looking at. And again, there's a lot more I want to look into. But one was our reactions to race module. So the two cancer screening modules that I already showed you were the most recent mammogram and the colorectal cancer screening module. So what I wanted to do, this reactions to race module contained a question. I believe I show the whole question later on, but essentially, as you can see down here in the legend, it was basically asking participants, when you go into a healthcare setting, do you feel that your healthcare experience is worse, the same, or better compared to those of another race or of other races? So in blue here are participants who said that they felt their healthcare experience was worse than other races. In orange was those who said that they felt their healthcare experience was about the same as other races. And those in green felt that they had a better healthcare experience than those of other races. So again, there's a lot more I want to do with this data, but just as a preliminary glance, if you look within group, for those who felt that they had a better experience compared to those of other races in a healthcare setting, and again, this is looking at women who indicated they have had a previous mammogram. About 55% of them said that their most recent mammogram was within the past year, compared to about 50% for those who said that their healthcare experience was worse than other races. So again, we don't have any significance or anything tied to this yet, but I do think this is something that's interesting as a preliminary glance and something worth digging into a little bit further. And if we look at social determinants of health, one of the reason I chose this question is it was consistent across 2022 and 2023. And also this one, I had done some previous studies with as well, but this question has to do with emotional and social support. So basically it asks them, how often do you receive the emotional and social support you feel that you need? So in blue here, we have the highest level of emotional and social support. So people that feel they always or usually receive the support they need, opposed to green, saying they rarely or never receive such support. And same thing if we're looking at the same most recent mammogram for women who reported having a previous mammogram. For those in the highest support category, about, again, 55% reported having their most recent mammogram within the past year, as opposed to below 45% of those within the lowest support group reporting that having theirs within the past year. So I wanted to do the same thing, looking at the same two reactions to race and social determinants of health for the colorectal cancer screening module. So again, this is looking at the reactions to race based on their healthcare experience. So this is for, once again, for those who are age 45 and older, have you ever had a colonoscopy or sigmoidoscopy? And for those who indicated that they felt that their healthcare experience was better than that of other races in the healthcare setting, about 65% of them said they have received a colonoscopy or sigmoidoscopy. And that was compared to about just over 50% for those who said they had a healthcare experience that was worse than other races. And for the emotional and social support, we see something similar. For those who indicated that they had the highest level of emotional and social support, it hovered right around 60% of participants in that group indicated they'd had a colonoscopy or sigmoidoscopy, and a little under 55% among reported the same among those who indicated the lowest levels of emotional and social support. So again, the point of me bringing this up, there's a lot more we want to do, and we actually have to build models to look at whether or not these are significant relationships. But I do believe there's other modules in BRFSS that tie into cancer data and that can give us clues to things that we may want to target or look further into when it comes to cancer screening. I just gave a really brief glance. There's a lot more work I want to do on this that I'm currently doing. But even within these modules, like social determinants of health, within BRFSS, this is made up of 10 different questions. The one I looked at, I just showed you, was just related to social and emotional support. There's also questions about social isolation. There's questions about reliable transportation. There's also questions about whether someone's receiving food stamps, whether they have reliable employment. That covers basically a lot of different modalities of social determinants of health are covered in that module. Same with reactions to race. And there's also the caregiver module, which is on the 2025 survey as well. The caregiver population, I think this is a really important one to cover as well. We know that caregivers, I think they have a lot of specific health needs as well that aren't always studied as heavily as they should be. I think we have, especially with an aging population in the US, I think we're going to see more caregivers. And when you have a population that is spending so much of their time caring for others and so much of their resources caring for others, it would be really interesting, as long as we have this module on here, to see the effects of that in terms of their ability to be screened, whether it's being screened for cancer or their ability to engage in preventative health behaviors. I think this is another module that has been underutilized that would be really interesting to dig further into. So again, my point is that I think there's a lot of modules here that can supplement cancer-related data. And finally, I wanted to circle back to this cancer survivorship module. This is an optional module. There have been a couple years in the past where this has been a part of the BRFSS within California. So it covers three different topics: pain management, type of cancer, and course of treatment. Within course of treatment, it does have questions about whether or not the participants have been in a clinical trial. It has questions about whether they received instructions for where do they go and who do they see for follow-up treatment. Did they get instructions written down? I think these cover a lot of really important aspects of cancer treatment and cancer care. So I wanted to bring this up because, one, I think it covers, again, a lot of important topics. It is available as an optional module each year. And I also think, as we mentioned, there's always state added questions available too. So even if this module isn't always able to be added to the BRFSS survey in its entirety, I think there's also the potential to add portions of this survey or portions of this module to the survey. If there are specific questions that may address, for example, the cancer plan, if there are specific goals or measures in mind that any of these may address, there's always a possibility we can discuss if any of these might help with that or help, I don't know, maybe of use. So I just wanted to bring this up and list them here so that everyone can see what's within this module and determine if they may be of use in the future. So, okay. All right, and with that, I just wanted to mention in general, finish with the importance of what I believe is BRFSS as a data resource. Again, BRFSS in California, it extends back to 1984. So you're getting a random sample of the California population. This is allowing for trends to be analyzed. Also, the fact that it's collected by every U.S. state and territory allows you to compare across state lines. It allows you to get nationwide estimates. And also the fact that we have those state added questions allows us to work with a lot of different, really a lot of different programs to discuss, how to customize the survey to address certain needs, and really just any public health topics of interest. We can always talk about adding them to the survey or address those in different ways. And as I mentioned before, BRFSS is free to request, so that data you can request. I do have that link in the beginning to fill out the DUA. When you do request it from us, we do have a county level data, so we do have a county indicator within our data set. As I mentioned, specifically for this group, we do have a lot of modules, especially within the rotating core, that relate to cancer screening and also potentially to cancer survivorship, depending on the year. And again, one thing I would stress is that, to me, I think there's a lot of optional modules and state added questions within BRFSS that are really useful to supplement really any type of data, whether it's cancer or otherwise. So I think a lot of people use BRFSS data to address their specific research question, but I just always stress to keep an open mind and see if there's any other modules on there, as long as this data, like I said, is a free resource, to check and see if there's anything else on there that can help highlight your research question or supplement it in another way. I think there's a lot of opportunities. So if you do have any questions, about what optional modules are available or how that data can best be utilized, please always feel free to reach out to us and ask questions. But I just wanted to bring that up and highlight that the best I can. And with that, thank you.
Thank you so much, Nick, for a very informative presentation in BRFSS. I'd like to open the floor for any questions and comments. But before I go on the chat, go ahead, Dr. Anderson. Please feel free to unmute yourself.
Yeah, the colorectal cancer module, two questions really. You mentioned colonoscopy and sigmoidoscopy, and you don't have in that module the fecal testing, which is the FIT testing, or the fecal DNA, the FIT DNA test. How do you ask that question, and how do you combine the data to make the overall colorectal cancer screening rate?
So there are other questions. The colorectal cancer screening module has other questions as well. For this presentation, what I had time to put together, that was the one question I chose to analyze because it had the largest number of people, I believe, that responded. For FIT testing, I have to see if that was.
Well, how do they combine those two? Do they just add them together and say that's the overall screening rate?
No, they don't have like an overall screen. So they do ask these separately. I think Vanessa in the chat mentioned this too. Yeah, so you can analyze them each separately. So they do have a separate. They have colonoscopy and sigmoidoscopy, and then they do have other ways of testing for cancer that are asked separately too. And then the overall adherence to USPSTF recommendations is what did you say? Includes all modes of colorectal cancer screening that are asked. So all of the ones that are discussed on the survey.
So if it's 10% FIT or fecal testing and 60% colonoscopy, that would be a 70% screening rate?
I have to check the USPSTF standards again, honestly, because it really depends on what their standards are.
Well, the
You
standards
might be
are
more familiar
once
than
a
me.
year for the FIT test, once every 3 years for the fecal
Yeah.
DNA test. And that's how I hope the question's
Yes.
asked. And if they answer positively to that, that's added to all the colonoscopy.
Yes. So it's a calculated variable. So it's taking into account, like, if they answered yes to any of these within that time period, then they were basically positive for fitting within those standards.
Well, since about 2018, the behavioral risk factor survey in California for colorectal cancer screening had an unexpected sharp drop, and it doesn't fit with the data we get from the government for the commercial plans or Medicare plans, actual real data, or even the federally qualified health centers. So that seems to be a problem. And one of the problems would be sample size. Is about 11% of the people that are surveyed nationwide California residents for this survey, since we're 11% of the population in the United States.
So the sample size, I know, like, from year to year fluctuates for us. So, for example, last year's sample was close to 10,000 participants. I have to look at what the national total sample size was.
You think it's only about 100,000 total?
I think it might be more.
I think it's much more. And when
It's
we've
much more
looked
than
at it, California has about the same sample size as a smaller state, much smaller state, one of the New England states. So that seems odd to me. How do they know that the sample size is adequate?
So I think a lot of the sample size that we collect also has to do with the cost of data collection within each state. That also varies drastically. So I can get more information for you about that, but I honestly have to look more into, like, what the sample size was year to year nationwide and within other states. But I know that's a big discussion, is how drastically the cost can vary state to state for data collection.
I just want to confirm with Nick and just let the group know that BRFSS, as Nick has said, the sample size in California is oftentimes smaller than other states due to cost, and the funding that we have for the program is that we receive does not adequately fund for us to collect a larger sample size.
So how much confidence do we have that it's accurate?
Well, go ahead, Vanessa, if you're going to answer that. I mean, the data are weighted.
Yes, that's
So
what I was going to say. The data are weighted, so they are taking into account the population, the sample size, reflective of California specifically, that is in the national data. That's taken into account. As far as like the overall screening rate, each of those are based on having responded to the mode that they were, the respondent said that they had actually had a screening within the designated recommended time. And then each of those can be, if they were calculated in the overall prevalence, responding in fact to adherence to the USPSTF recommendation, that's taken into account. If yes, you had a fit test in the last year, if you had a sigmoidoscopy in the last 5 years, all of that is taken into account into the overall USPSTF adherence. As far as it becoming, I know the concern is the screening level in California has decreased over the last how many years?
4 years.
Yeah, so I've noticed that too. The one factor in consideration is, well, there's a few things. One, 2020, the screening had gone down anyway because folks were not going into clinicians to get their routine screening from the pandemic. So that might need to be looked into separately. Other things are the modes in which the method of screening has changed over the last few years. They weren't offering a virtual colonoscopy. I know some providers don't offer colonoscopies. They do the fit tests every year, unless you insist to your provider that you want a colonoscopy, and it's only if indicated that you've had a cancer, colorectal cancer in the family or genetic.
But that shouldn't make any difference, since if you do a fit test every year, you would be counted as screened just like a colonoscopy, and their
Correct.
tests are equivalent.
Correct. So yeah, so it's gone down, but it would be worthwhile, like I said, to maybe look at each of the individual tests separately to see if the fit test maybe has gone up, the colonoscopy has gone down. I'm not sure why, the overall it has gone down, but those are the only kinds of things that we could speculate on as the types of tests not being able to go in and get a test at all in the last few years.
Well, the colonoscopy lasts for 10 years, so the COVID would affect only about a tenth if you just do the straight, if it's absolutely, if everyone's just getting, if they're staying right on their 10 years. So the COVID wouldn't have affected the colonoscopy rate much.
Right. Yeah. Yeah, it would, I don't know exactly what could be the issue behind it. I know we did drop, though, California did drop in their screening overall.
Oh, yeah, we were in the upper half or upper third, and now we're the last of the nation. So, and like I was mentioning, I don't understand what it is, because the other measures of screening in the state that are accurate, that are actual, not survey data, but actually in commercial and Medicare and the federal qualified health centers, is actually above average for the country. And so it just doesn't make sense. So I'm confused by it. Sorry.
Yeah, the questions on the BRFSS have changed as a result of the different changes in screening modalities. So, I mean, that could be, I mean, we're looking at self-report for the BRFSS. So we would have to look at other sources of screening in order to compare to what we're actually getting from survey, self-report. Because the questions, like I said, they did not, prior to 2018, they were asked on the even year. So 2018 colorectal cancer screening questions were actually different from 2020, and then they changed again in 2022. So
that's interesting.
yeah.
Because 18 was our highest year. Interesting.
Yeah.
Thank you so much, Dr. Anderson and Vanessa. We will take a closer look on this. We'll need to review it further. And then I just want to acknowledge the other questions on the chat. And I see, Shannon, would you like to go ahead and address your few questions on the chat?
Yeah. So first, I wanted to ask, you presented mammography data and said that that was for women. Does that data also, does that question only appear to people who report sex assigned at birth as female or report woman as their gender in the data set? Or is it inclusive of everyone who needs mammography screening, whether or not they identify as a woman?
So I believe, I will double check. I believe that one is based on sex at birth, but I will double check. I have to look at the coding specific for that question, but I believe it's based on sex at birth. But I will double check. Because I know in the coding it's very specific, like I will look into that for you, but I'm pretty sure that's how it's coded. Because it's one of the, it's screened out like immediately in the beginning.
Yeah. So Nicholas, when you're presenting data like that, if the gender question in the SOGI data module that we use in California, because I don't think we use the BRFSS standard. I think we have our own state SOGI data module that's in there. If that includes transgender populations, you don't want to present the data as only being for women, because there could be trans men and non-binary folks who were assigned female at birth or were designated female at birth by their medical health providers when they were born, and they could have a different gender identity.
Yeah,
so just to keep
point.
that in mind moving forward, because your slides didn't have that word on there. It was how you were presenting it and talking about it.
No, you're right. I should, I can absolutely be more specific about how that's coded in the survey, about how they get to screen who was asked that question or not, and like how that's actually, they get to that. So thank you.
Yeah,
sense.
yeah, no problem. And then I was also wondering, for BRFSS moving forward, will the SOGI module still be available and included?
That is a great question. So there are a lot of changes taking place at the federal level that are unfortunately out of our hands. So right now, state added questions are not being affected, as those are, done through the state. The SOGI module is an optional module, and that is done, obviously that is supported by the CDC. So those modules are going to see some changes. So currently, at least for 2025, I don't believe that module is currently available to us. So I think right now there's a lot of uncertainty about what if basically I think right now they're not available, at least for 2025. And I don't know, unfortunately, what the future of that's going to be. I think there's still a lot up in the air, unfortunately, for some of those modules.
Are we going to add state LGBT identifying questions into our 2025 BRFSS since the state added questions aren't being affected?
So I think this happened basically last minute. So I don't know, basically when this happened, they went back to the 2024 questionnaire and said, we basically are just going to use what was approved and pushed forward the 2024 questionnaire and took out anything that was not supposed to be in there essentially at this point. So I don't think we had anything that was funded. For Sandy, correct me if I'm wrong. I don't think we had anything that was funded for 2025 when this occurred.
I want to agree with you, Nick. Will impact, I believe, 2025 going forward, we do understand the importance of this
Yes.
module. Will impact 2025, but I think going forward for 2026 is our intent to add that back in.
Okay, yeah, because I mean, we're talking about 10% of the California population who will be completely
Absolutely.
excluded and invisible in our 2025 BRFSS data with
When
that
this
module not appearing in there.
when this happened, it happened very suddenly when proposals basically had already come in, and there wasn't
Yeah,
a
I mean,
lot
in the
of
middle of
specific.
the chaos
Yeah,
that
but
is
no, we agree with you 100%.
ensuing right
It's an
now.
incredibly
Okay.
important module, and I think all of us are obviously view that as an incredibly important module to find. So next year, I think we have a lot of time to basically discuss and find ways to include that back into that's important to all of us. But yeah, I think we can definitely find a way to try to add that back in as a state added question next year. But
Great. And if there's any committees that are going to be formed on how to best ask those questions and what responses should be included, sign me up. I already volunteer.
that would be great. Thank you.
Thank you, Shannon. Thank you, Nick. Vanessa, you had your hand raised. Do you have any addition to that answer?
Yeah, I was just going to add that there's no reason why we can't add the SOGI module as state added questions. They could be purchased as state added questions if you were to modify a word within that module or add a question. If you change it slightly, it is considered state added questions, won't be collected by the CDC since it's not verbatim word for word, but otherwise we could keep going as long as funding is available. We could keep using those questions in the California BRFSS as state added questions. Yeah.
Thank you, Vanessa. And for those who are listening, I'll just read over some of the questions addressed in the chat. When will the 2024 data be released? The California BRFSS program releases the data after September, depending on when CDC releases the data. Another question is the turnaround time for receiving data for the year. We request after we've submitted data use agreement. And then Sandy said, we work with IT in setting up a folder, so it can take up to 4 weeks, but usually it will not take that long. And then just going over the rest of the questions. I don't see any more questions. Are there any other questions from other participants of this webinar? Right. So to wrap it up, please take a moment to complete a short webinar evaluation, which my colleague Joyce had already shared in the chat. We'll have one more presentation this fiscal year, and it's on June 18th. Any recording and slide deck will be shared with all of you via email. Again, thank you so much for joining us today, and have a great rest of your week. Thank you, Nick. Thanks, everyone.